All right, I want to say welcome or welcome back. I've done part one and part two, so I'm going to quickly advance through some of these. The whole point is to diagnose and treat some stigmas about physicians. Since the days of Hippocrates, people have asked others, "How are you feeling?" But it's more than time to ask who's taking care of the caregivers. So you might be a physician, you might be this group, you might be concerned about somebody who maybe is no longer a superhero. You may know that 40% of physicians admit regular self-medication. 15% of physicians have admitted to feelings of suicidal ideation in the last 24 months. And virtually 100% of physicians have experienced burnout at some point in their careers. So these slides are meant to be clinical and factual and focus on the fact that we can certainly diagnose and prescribe treatment, but also we can provide care at an individual level and organizational level. Here's the clinical definition from the AMA: depressive disorder that can paralyze you. If in fact 60% of the physicians in your practice group are experiencing burnout, look to the left and look to the right, or look in the mirror. Think of burnout as a continuum. I'll give you two ways to self-diagnose. Resiliency can be defined as the capacity to adapt successfully in the presence of risk and adversity. So pick a number. There are two sides of this coin. It's thought that burnout and resiliency are directly related and inverted. If you're really daring, ask your work team or others, "How am I doing?" Or have you noticed any changes in behavior? For instance, am I more abrupt or judgmental or impatient lately? This is part of the assessment that I commonly provide. Another is to use validated and reliable assessments. The Maslach Burnout Inventory is a good one. For that, once we've got data from multiple sources, we move forward, just like any scientist or any physician does. Nobody succeeds by themselves. We take the data and then we provide some treatment. Healthcare is a team event. So two key questions. How do you know if you're suffering from physician burnout? And what are my options for treatment and care? Think of Scrubs. I met a doctor recently who said, "I envy those actors. They get to say what we cannot say." And he still watches reruns. So let's go to the science. This elegant slide looks at physician burnout and gender differences at different stages in careers. I've already spent a fair amount of time on this. The tragic big picture is that roughly 50% of all physicians complain of burnout. And that 50% is higher than any other profession in the United States. By practice group, primary care is orange, surgical is blue, internal and peds is brown, everybody else is yellow. We know from MRI imagery the fact that the person on the left represents a person with hope and positivity, vision, compassion, higher resilience. The one on the right, stressed, frustrated, confused, alone, not sure to speak to. We know that physicians with burnout have these symptoms, behaviors. Tragic, in my opinion. My hunch is you know somebody who demonstrates these behaviors. This is the crux of our slide deck, and the real reason, 5 reasons why we get to work with people. Cognitive behavioral therapy, CBT, is a psychological process. It recognizes choice and personal strengths and includes regular behavioral feedback. I hire a dentist when I need dental work, and I don't understand why some people don't hire a psychologist when they need to develop resilience for themselves or for their work team. So that's what we do. We assess and diagnose. Behavior change happens in these 3 ways. We modify the cues, change the routine, and it's an ongoing, progressive, iterative process. So let's look at the science. Treatment and care at an individual level. I've discussed this slide previously. Start with an assessment like the Strength Finders. Figure out what your key strengths are. Develop daily practices. Reinforce with a dream team. Incorporate those values into your office. And get past that silly notion that delayed gratification, which got you through med school, is going to sustain you in your career. It simply will not. So, treatment and care at the individual level. Here's another set of ways to develop more meaning and purpose. This is a predictor of career success. Meaning fluctuates, just like seasons in our lives or seasons in a year. Think of that early career, mid-career, and late career slide I showed you a moment ago. So here are 3 tactics to help you increase meaning in work. All 3 imply choice for some constructive behavior. Think of flow as a magical balance between skill and challenge, or effort and results. You may spend 2 hours in surgery and not know that any time has passed, or 2 hours supporting a patient who's frightened before surgery and needed you to comfort that person. Locus of control is a simple way to describe, but it's really hard to practice consistently. Internal locus of control are the variables that you can control. It starts with recognition. You have to like what you say and do, and you have to focus on what you say and do and not focus on the things you cannot control, like national health care changes, that administrative policy, that insurance dictate, that procedural compliance requirement. External variables I've already listed. There are plenty of scary and cynical examples, from Dilbert to Snoopy. If you find yourself being cynical, that's an indication of burnout. So let's focus on the visions. Visions define meaning for work groups. Think of a flag flying outside your hospital or your clinic. And if your vision is nearly impossible to attain, such as our team is going to strive for 100% compliance or 100% healthy care for our city, that tells me that maybe you're not focused on the proper vision. We need bigger flags. We need bigger flagpoles. You may know that physicians have doubted the need to wash their hands for decades, and that regular hand washing is associated with reduced rates of infection. It's also associated with rigidity. Some docs are not willing to wash their hands as often as they know they ought to. So a coaching question could be, what's going to be meaningful for you to change at work? Another slide at the individual level. We need to nurture personal wellness. The irony is that physicians often have the knowledge. They know what to do, but excuses or bad habits or guilt or silly whatevers can get in the way. There's plenty of evidence to support the following 5 tactics. Most is being incorporated into med school training now and into residency, and all are available with CME credits. Let's start with lack of sleep. It's the biggest reason for safety accidents, injury, and illness. We know that exercise increases serotonin levels. We know that endorphins are associated with positive feelings. And executives and physicians are not the only ones who need regular medical care. Cobbler's kids need shoes, and physicians need a primary care physician. Gratitude is the deepest expression of appreciation for life. It can be measured using fMRIs. It can be measured by looking at blood pressure. How often do you express gratitude for your patients or your colleagues? And it can be measured alongside patient care metrics. Learning is a feedback process. It implies interaction and novelty. Learning agility defines your career success. If you're rigid, it will limit your career success. Countless studies and countless examples. Freeze framing and mindfulness training has been taught to the military for decades. There's a neural reaction that enables people to reprogram their responses to stimuli so they can endure the chaos of guerrilla warfare. And in the same way, we can learn to endure late night full moon rotations in ER. You know the stats. Mindfulness and stress reduction is now a mandatory course of study in many residency programs. We can measure our response to triggers, we can moderate our response to triggers, and we can be more productive. Moving on, there's research in gerontology and happiness. It's really clear about the need for strong personal relationships. My experience is that most physicians lack close personal friends. And we need, on average, 6 that we can call in the middle of the night, should we need to call them in the middle of the night. There's a popular engagement survey conducted by Gallup called the Q12, and it measures who's my best friend at work? Or do I have a best friend at work? This is an indicator of trusting relationships with others. We need them. Please cultivate them. Faith, by definition, is a belief in something larger than life itself. And those who actively adopt the practices of going to a church or regular prayer, we know they live longer, they have higher resilience than those who choose not to be religious. How they do so varies tremendously. Last week, I joined a webinar with a physician who advocated actively praying for patients when you feel called to do so. Now, I'm going to say that, but naturally, every physician and employer will define how you practice your faith. I will say that I often close a coaching session with a private, silent prayer that the client do their work in the best ways that they're capable of moving forward. So that closing ritual enables me to move on to the next client, and I invite you to use that if it helps in your clinic or your practice. Hobbies can be defined as the activities we choose to do for pleasure or entertainment. Plenty of research shows that the best way to mitigate depression is to volunteer, to actively give time and resources to others. So those are the individual ways that we can provide treatment and care for burnout. But it's time to close this little slide. So next steps, schedule a confidential consultation if you wish at my website, action-learning.com. Call me or advocate for any services. There's plenty of free information on the website. Be glad to talk immediately. Call soon. Thanks. I'm Doug Gray. There's nothing scary about this process. We need to take care of the caregivers. Thanks.